Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And let me introduce the topic for this session. We are on the occasion of World IVF Day, and we are coming with very important topic, that is infertility decoded, an overview with AI innovation and recent advances. As we are moving digitally forward, so in the field of medicine, science also it become important to move in the certain kind of AI and their innovations. So without any further delay, I would like to invite host for this webinar. She is none other than Dr. Sharda Jain ma'am, and let me share some of the achievement of ma'am. Ma'am is the Secretary General of DGF, that is Delhi Gynecology Forum, and founder and chairman of North India Gynecologist Forum. Hi, ma'am. Welcome to the show once again, ma'am. You are always there to guide and teach in the innovation in the form of medical science. So, ma'am, it is a great honor to have you. Now, I would like to invite and hand over this session to make this session move forward. Over to you, ma'am. You can proceed from here.
Thank you, Faraz. At the outset, my sincere regards for platform given to us on Med Talks. Is a very popular platform where lakhs and lakhs of doctors are associated. And today is a World IVF Day. And we are not only celebrating this breakthrough, medical breakthrough, but we are here to tell you the extraordinary journey of India, the courage, the evidence, and the excellence in which it has shown. Uh, as you all know, that in 1978, on the 25th July, that is this day, Lucy Brown was born in United Kingdom, and that is 47 years ago. And exactly 67 days after this particular incident, Dr. Subhash Mukhopadhyay, another stalwart, uh, produced an IVF baby, Durga. He had no lab, he had no grants, he had no global applause. In fact, he had a grit and brilliance with him. But instead of getting kudos from the colleagues, he was facing the disbelief, rejection. He was ridiculed by the colleagues as well as by bureaucrats, and he committed suicide uh, as a result of the same. And much later, posthumously, his work was regarded, and it is a story. So we are here to salute on this particular day our great hero of India, who started the journey of IVF in our country. And then you all know that thereafter, in 1986, Dr. Hinduja from Bombay and Dr. T.C. Anand produced baby Harsha. And now we are the second largest IVF market as far as world is concerned. We have 3 lakhs IVF cycles annually. At the same time, we have 3,000 IVF clinics. And I think today we are going to have very eminent people on this door. I have another host, Dr. Sujata. Dr. Sujata is a secretary of Delhi ISAR. So, Dr. Sujata, say a few words before we invite our distinguished guest.
Good evening, everyone, and thank you so much, Dr. Shadajan ma'am, for inviting me. We all know, as ma'am said, World IVF Day is the ultimate thinking of human brain. Unless until we think, we cannot do it. So human has thought to produce an embryo in lab, and that helps so many infertile couples. So this day is celebrated to give tribute to all the scientists, clinicians, embryologists, all nurses, paramedics, our counselors, each and everyone who are involved in making this journey possible. And I congratulate each and everyone who are doing IVF procedures, and I want to congratulate Dr. Shada Jan ma'am and everyone to plan this webinar with our esteemed speakers, which we are going to hear all those 3 talks. So thank you so much, ma'am.
So let's have our first speaker, Dr. Brigadier Sharma. Dr. Brigadier Sharma is very fondly known as the guru of gurus. He has trained hundreds of gynecologists, and also he's known to train embryologists. He has started the ART center at Delhi. He started in Pune and Southern Command. And Yes. Should I go ahead, sir? Doctor is a Vishis Seva Medal from the President of India. He has received Lifetime Achievement Award from DGF. He has also received Gynecologist of the Year again from the DGF. He has been advisor to many civilian uh, ART centers as an ART expert. He had been advising them, and I think today we are going to hear from him artificial intelligence in infertility. You'll question that for an ordinary gynecologist and for ordinary public, what is the advantages of it? I'm also do not know much about AI. I think we will definitely hear from our esteemed guest. But what I can feel is that you are very close to accurate diagnosis. It gives you personalized care, and at the same time, it gives a lot of time of automation as for the administrative part is concerned. So the doctor has much more time for to give it to the patient. So I will not be with you in between with you and Dr. Brigadier Sharma. So over to Dr. Sharma for your deliberation. Faraz, help.
Good evening, madam. Thanks for inviting me to speak on artificial intelligence in infertility. How do I change? So it was in April that we got the news that the first AI baby has been born in Mexico using automated system by Conceivable Life Sciences, which was done on a 40-year-old woman who had repeated IVF failures. In this particular cycle, they used the egg donation, and there was no human intervention as far as the sperm selection, immobilization with laser, and ICSI by AI system and robotics was done. It was a big leap forward. And with another 2 months later, there was a full page advertisement or a about the AI, which is going to change our life. So AI has become an integral part of our life now. It was word AI was first coined by McCarthy in 1955. It is defined as the ability of machines to learn and display intelligence, which is in stark contrast to the natural intelligence demonstrated by human and animals. AI enables machines to perform tasks that normally require human intelligence. The basic three methods are used: the machine learning, deep learning, and the computer vision. AI excels at pattern recognition, which we may miss, and predictive modeling using a large data sets, which may not be possible for human beings. Edward was the first, Shortleaf was the first man, doctor to, write a program for AI in the medicines. And since then, AI has intruded into all the fields of the medicine. There are 10 areas where AI is enhancing the IVF outcome. The first of them is the time-lapse imaging. Now, embryologists, normally see the embryos morphologically, and it is a very subjective and inconsistent method of, assessing the quality of the embryos. But AI system, when also attached with the time-lapse imaging, the stationary pictures, then can give a better accuracy. There was a study which was developed an AI model using a deep learning to predict live birth outcomes from the time-lapse images, achieving a confidence score that significantly improved the embryo selection. And AI provides objective, reproducible assessments, reducing the human errors and enhancing the IVF success. Secondly, it also helps in the sperm selection, which is normally very time consuming and prone to variability. The AI helps by selecting the sperms by a AI powered microscope like the Mojo Assess, which automatically evaluates sperm motility and morphology, achieving up to 97% accuracy. So it helps in a proper selection of the sperms and potentially improving the fertilization outcome. Thirdly, it also helps in predicting the IVF success, because the patient wants to know what is the likelihood of my success. Most of the time it is based on the limited clinical parameters and expert judgment, but the machine learning models analyze extensive data sets to predict the IVF success and multiple pregnancy rate. One such study was developed model using the XT boost, achieving accuracy up to 71.6% for pregnancy prediction and 73.2% for multiple pregnancy. So it gives a personalized treatment plans and reduces the risk of multiple pregnancy. Fourthly, during the ovarian stimulation, our treatment is based upon our experience, which may not be optimal for all the patients. So it has to be tailor-made. The AI models analyze the patient-specific data to recommend a tailored ovarian stimulation protocol so that we can prevent the ovarian hyperstimulation syndrome. Fifthly, automatically the automated ultrasound imaging analysis, which we do not have at present in all the centers, and most of us, do the manual assessment of the ultrasound images to predict the size and the number of the follicles. But when the AI algorithms are used, they automatically analyze the ultrasound images, providing consistent measurements of the follicles and the endometrial thickness. So thus improves in the monitoring accuracy and reduces operator variability. So we will know beforehand only how many oocytes we are likely to get. Now, this is another advantage of the AI driven, because earlier the embryoscope images were used. Now, in this, the time lapse videos of the embryos are integrated with the spatial and the temporal pattern to assess the quality. So that means you are seeing the embryo from the beginning till the blastocyst stage and how it is dividing and the way it is dividing. So the study was introduced using the Coach STEM framework, which outperformed the traditional method of embryo grading, and it gave a more comprehensive and accurate assessment of embryo viability. Now, we all know that the PGTA is required in a selected group of patients, but it is an invasive methods. But AI models predict the embryoploidy status using non-invasive methods like spent culture media analysis. It reduces the risk and the cost associated with the PGTA while maintaining the diagnostic accuracy. The patients have got a lot of questions during the management of infertility, and they may call upon your assistants or the doctors directly. So their inquiries are mostly handled manually, may lead to delays and inconsistent information. But when AI powered chatbots are used, they provide instant response to the patient queries, schedule appointments, and offer emotional support. It gives the patient satisfaction and timely and personalized communication. Normally, what we do in the clinics is managed manually, and it leads to a lot of inefficiencies and errors. But AI analyzes the operational data of any clinic to optimize scheduling, resource allocation, and inventory management. It improves the clinical efficiency, reduces the cost, and enhances the patient care. Now, embryo selection is based on a limited genetic information which may get by PGTA or by the expert judgment. But AI enables comprehensive genetic screening, and it can assess almost 900 conditions, so which provides the prospective parents with a detailed information to make informed decisions, though it may raise some ethical concerns because many of the embryos may be discarded even for the smaller expected genetic abnormalities. Regarding accessibility and potential discrimination is also there, because this technology may not be available to the poor patients. The five future focus areas where AI may further enhance IVF are the AI-driven embryonic genomics without biopsy. Now here, researchers are developing deep learning models that analyze cell-free DNA and protein signatures from the spent media. And with the help of this, they can tell us more accurately, without any invasive method, what is the aneuploidy or euploidy of the embryo. We all know that genomics, proteomics, transcriptomics, and metabolomics are important parameters, but most of the time we didn't use it because they were all scattered. Now, when you put all together with the AI, so it leads to a hyper-personalized treatment plans for embryo selection and timing, improving the outcomes dramatically. So early stage trials are already integrating AI with the endometrial and embryonic transcriptomic data. That means you take the uterine secretions and the embryonic transcriptomics and put it into the AI, and that will tell you what is the chances of pregnancy and when to implant. Now, the fully automated IVF labs using AI and robotics to handle sperm sorting, oocyte handling, fertilization, and embryo culture in real time is going to reduce the human errors, standardize the quality. Startups are already developing AI-guided robotic systems for embryology like robotic ICSI and embryo culture monitoring. Now, because we know that because of the lifestyle and all, the reproduction in the human race is reducing, and we need to predict it early. So AI could predict fertility decline years in advance using longitudinal health data, variables, and genetic markers, enabling early egg and sperm preservation for intervention. So we can, select from the general population who are the patients who need to, freeze their oocytes early in comparison to others. The Apple Health and the Google's AI health divisions already moving towards predictive reproductive health analytics. Now we have been dependent on the era for knowing the window of implantation, but it is also it's a very not a dynamic; it's a static test. The more accurate window of implantation timings could significantly improve the implantation and live birth. AI-powered platforms are being tested now as dynamic models for endometrial receptivity using hormone levels, ultrasound, and transcriptomic data. So putting all this together, they can help us to decide when to transfer the embryos. So AI will significantly enhance IVF by improving precision, personalization, and efficiency across various stages of treatment. While these advancements offer promising benefits, they also necessitate careful consideration of ethical implications and equitable access. Thank you very much.
I think you've had heard the masterly deliberation by Dr. Sharma, and I think we are all hoping that in a very near future we will have AI to aid us in patient selection, in precision, and in outcome of these patients. Now we have. Thank you, Dr. Sharma. You will be here with us for taking up the question in the end.
Thank you.
Now we invite Dr. Gauri Devi, our second speaker. She's the director of Gauri Hospitals Limited. She's the director of Ridge IVF Group. She's the past president of Indian Fertility Society. She has been expert as far as fertility preservation is concerned. She is president elect for fertility pre-selection group, and she's a member of executive body of both NARCHI and AOGD as far as Delhi is concerned. She's highly decorated person with many lifetime achievement award, and today she's going to speak to us on fertility preservation. So over to you, Dr. Gauri, to make this deliberation. Dr. Gauri.
Good evening, everyone. I think somebody will have to change the slides.
Yes. Faraz, please help.
Next, please. I shall be talking to you today on fertility preservation and overview. Fertility preservation mean? We use all the available technologies to preserve an individual's fertility for future use. And the reproductive capacity can be affected by age, any of the genetic syndromes like, some of the syndromes like Klinefelter's or Mosaic Turner's, etc. Any surgery on the gonads like ovaries or testes, whenever we use any chemotherapy agents in onco patients. Next. Now, if we look at the fertility preservation, we have to have a clinical care team where the oncology team, besides the oncologist, we should have a rheumatologist, a gynecologist, an endocrinologist, hematologist. This whole, besides that, there should be, of course, fertility specialist and embryologist. One of the other important is transgender population, where transgender women or men, when they want to change the sex, they might want to preserve their fertility. So there must be a transgender person also in that. Now, another important thing is a coordinator. Why? Because on one side is a patient with cancer. To her or him, we are talking about fertility preservation. So they may not be able to comprehend. So they on one side they have to go to that department. Here there is a fertility preservation. So a coordinator is very important. Next, please. Next slide. Because cancer survivors are better treatment, the number of cancer survivors are increasing. More than 80% of children and adolescents with cancer, they become long time survivors, and when they get out of this cancer thing, then they will think of having a partner and having a child. That is where these preserved embryos come in. There are many women who are postponing childbirth. Why? Because either they are busy with their work, or they want to postpone the pregnancy because in the cities there's no one to take care of their children, so they want to postpone it. At the younger age, if they preserve their oocytes, those oocytes have a better quality when they want to have a child at the elderly age. Next, please. Next slide. Send next also you can put. So this has been used. Next, please. Semen preservation has been used for the last 50 years. But now, what are the indications that we have? One is any malignant condition, delayed childbearing, or benign conditions. Next, in malignant conditions, next, please. It could be any pelvic, extra pelvic, like bone cancer, breast cancer, etc. Pelvic conditions where there's rhabdomyosarcoma or gynae malignancies like cervical, vaginal, uterine, uh, ovarian, and whenever there's systemic lymphomas, here we need to preserve it. Next, in benign conditions, next, you have certain of the autoimmune diseases like SLE, or you have rheumatoid arthritis. Here, the treatment given is sometimes methotrexate, sometimes they give immune suppressant agents. There, the fertility is affected. There also, you will find a low AMH and you will have to preserve the fertility. When you have to do a hemopoietic stem cell transplantation, you completely irradiate the bone marrow. So what happens? The patient's gonads are affected. There you have to preserve the fertility. So as I told you, benign ovarian tumors, endometriosis is another thing where extensively, if the ovaries is affected, there this thing goes down. Better to preserve, especially in younger age group, and also gender reassignment procedures. Next. Next. So whenever we do chemotherapy, depending upon the age, medication, and dose, both in female and male, there is effect on the gonads. How? Coming next. Oh, sorry, because the slides are being projected. Some of the slides are missing the pictures. Sorry, but I'll tell you what happens is when you give chemotherapy or radiotherapy on gonadal cells, there is cell death because it affects the primordial follicles, and the primordial follicles come in numbers, and there's a cell death. Next, please. And calculating agents, they are high risk for ovarian failure. Antimetabolites, they are lower risk. Platinum ones, they interfere with the DNA replication and transcription. Taxanes, they will affect the cell structure, microtubules. Next, please. So by radiotherapy, by direct action or indirect action, what it does is DNA damage and cell death. So there is a apoptosis, mutagenesis, mitotic catastrophe, and ultimate thing is there is a cell death. Next, please. Next. So by radiotherapy in female, male, I'll talk about male. Previous slide. Previous slide. See, in male, again, the photographs are missing, but I'll tell you, when it affects the spermatogonal stem cells, it will cause complete azoospermia. When it is affecting Sertoli cells, it causes testosterone deficiency. Sometimes when growing germ cells are affected, it can either cause partial azoospermia or permanent azoospermia. That is the effect of radio and chemotherapy on male infertility. Next, please. In female, next, In female, what happens is whenever there is radiotherapy is given, it will affect both the uterus and the ovaries. And uterus, once it undergoes a radiotherapy, that is a high risk pregnancy in case she conceives later. Next, please. Now, uh, what about how much dosage can these patients take? In the chance of a premature ovarian failure, it is 4 times more in adolescents and 24 times more when they are adults between 21 and 35. When you use 2 gray radiation, it will destroy 50% of the ovarian reserve. 5 to 20 gray will completely destroy the ovarian function. Next. Radiotherapy, for a given dose of radiation, younger the patients are, later is the onset of premature menopause. If you see, the effective sterilizing dose are 20 gray at birth, whereas at 30 years, it is even in 14 gray, they will have a POF. But mind you, there is no model which can predict the age of failure. Why? Because it is highly individualized. Next, please. Now, there are certain barriers which will interfere with what is happening. Why are we not able to cut across and get more and more people to come for fertility preservation? Next. As you can see, there is a lack of knowledge of fertility preservation. There is a time constraint. Some of the cancers are very virulent. So there is no time to waste. Patient himself or herself is very apprehensive. No, no, I am not bothered about the fertility. First treat me. Let me at least survive. Then if they want it, lack of providers. That is also a problem. Then lack of insurance. Insurance doesn't cover fertility preservation. Then financial burden to the patient. One side is a cancer treatment. Other side, you have to undergo an IVF, which is also expensive. Next. Coming to the patient barriers are they have no knowledge of treatment of fertility, no knowledge of fertility preservation. They are overwhelmed with their cancer diagnosis. And some of them are worried. Suppose I have cancer, will my progeny have also cancer? Should I go for a preservation? Now, coming to physician, there is limited time for action sometimes. Even if the physician wants, there's no place where he can refer to. So these are some of the things that is happening. And in whenever there is estrogen sensitive tumors, there, if you do a stimulation, it may not be very good for the patient. These are the barriers for the physician. Next. Let's see, come to the Indian perspective. Here we have a Fertility Preservation Society of India. It was established by Dr. Nalini Mahajan's efforts in 2015. We are making a progress, but still there is a lack of multidisciplinary approach, lack of knowledge among healthcare professionals and patients. There's no good referral system, and we need to have a cost effective system for poor economic status. Next. Next, please. Next. Next slide, please. Now, coming to the female fertility preservation options, we have medically, we can do oocyte cryopreservation, we can do embryo cryopreservation, we can do what is known as IVM, where there is no time. We cannot waste time stimulating the ovaries. We can do very minimal 2 or 3 days of gonadotropin and an HCG and do an IVM. And if nothing is possible, we have an injection GnRH analog, which we give it till the stimulation, till the time the chemotherapy is being given, which will protect the gonads to some extent. Surgically, we can take the ovarian tissue and cryopreserve it, or we can, when they are undergoing irradiation, you transposition the ovary to a little higher place so that it doesn't come in the way of radiation. Next, please. In men, we can do sperm cryopreservation. We can shield the gonads when they are undergoing irradiation of the pelvis or upper thigh. Testicular tissue cryopreservation is there. Testicular tissue, it's being done especially in prepubertal men, but mind you, it is still experimental. Ovarian tissue is an established cryopreservation method, but testicular tissue is experimental. Why? Because till date we have not been able to get a child out of that preserved testicular tissue. They have been able to do in research up to spermatogonia, but we have not been able to get a spermatocyte. Next, please. So, as you can see, the success rate of cryopreservation, it is, when we do this, less than 35 years when we are doing, we require at least 24 oocytes for cryopreservation. And likelihood of using these oocytes is only 12.1%. Next, please. I think you can skip it. There are guidelines by Canadian and ASCO, that is the American Society. If anyone is interested, there's a complete booklet on ESHRE Guidelines 2020. Actually, my slides being projected from some other place, they are not giving out the full pictures. So I had put important guidelines. What ESHRE says is oocyte cryopreservation, embryo cryopreservation, they are established and there's a strong evidence to do that. And one thing more ESHRE says is that when you're doing a embryo cryopreservation, take a proper consent. Why? Because a cancer woman has cryopreserved the embryo. Suppose the husband leaves her. She cannot use that embryo on herself unless that husband consents. Suppose he is married again, he may not consent. So it may be wiser to uh, fertilize, to preserve the oocytes rather than the embryos. Next, please. These are Canadian and ASCO guidelines. When is the best time to talk to these patients? Before the cancer treatment begins, if you are going for a gender affirming treatment, because transgender, they undergo drastic surgery. In women, they undergo mastectomy, ovariectomy, both the ovaries are removed. So before that, you have to preserve. In transgender men, they undergo castration and complete emasculation, and then they take female hormones. So before that, they will have to preserve their sperm. And some people, I would like to tell you that whenever you find a disease that may affect your fertility, that is when you tell them, like endometriosis, you tell them when there are abuse, endometriomas being removed, you tell them to preserve their fertility. And some of the, one or another thing is that some women, they preserve their ovarian tissue, and when they reach the menopausal age, they get it positioned in the ovarian fossa so that they can postpone their menopause to some years. This is also being tried. Next, please. Next. So, just one or two slides where at least 1 year interval should be there between chemotherapy and pregnancy. Radiotherapy to the uterus, it's a high risk pregnancy. Stop tamoxifen for at least 3 months before attempting pregnancy. Next. The clinical outcome from fertility preservation technique, it is quite good. I would say that people have reported anything from 20 to 40% pregnancy rate when they come back. Those authors, it's not coming in this slide. This is what the outcome is. Next, please. So, take-home message is fertility preservation should be an option for all patients undergoing toxic treatment. Referral pathway between an oncologist and infertility specialist should be there. Oocyte cryopreservation, post-pubertal unmarried females should use. Embryo cryopreservation requires a partner or a donor sperm. Ovarian tissue cryopreservation, it is for both reproductive and endocrine function of the ovary in prepubertal women. IVM is an innovative technique, but you should have a good lab and certain changes there. GnRH agonist, the only pharmacological treatment, a debatable thing, but when nothing else is there, give that. And transposition can be offered for those at risk of pelvic radiation. Next. So to conclude, next please. As the number of cancer survivors are increasing, need for fertility preservation is emerging. It should be a priority when treating children or adults reproductive age with agents that may have hazardous effect on the reproductive system. Gonotoxicity should be kept to a minimum. Next. Okay, thank you very much for a patient hearing. And I'm sorry about the slides because the slides were not showing all the pictures that I put in. Thank you very much. That's the end. You
I
can
think,
put.
yeah, I must salute you, Dr. Gauri, because this shows how great teacher is there. All barriers you have broken. That the slides were not all right, but I think you conveyed what is fertility preservation, what are the main methods of fertility preservation in women, in men, and I think so great future is there, and I think you are the president elect for Fertility Preservation Society of India. I think in your tenure things will definitely improve, and ordinary IVF experts should be able to grab these techniques which you have mastered. So thank you very much, Dr. Gauri. You will be there in the end. We will have
Yeah,
the third speaker. So now
yeah,
we have the third speaker, Dr. Shivani Gaur. Dr. Shivani Gaur is the youngest speaker today. She may not be as senior as Brigadier Sharma and Dr. Gauri, but she's a very powerful. She has made a name for herself as far as IVF word is in India is concerned. And I think, when the surrogacy days were on fully thrive, she was the queen of the surrogacy as far as Asia was concerned. She's the one of the most liked teacher by DGF courses on infertility because she is patient centric, she's success centric, and she grabs what is new which can improve the outcome for the person. So over to you. We hear Dr. Shivani. She's going to update you what she feels the best in the last decade or so. So Dr. Shivani, over to you.
Respected Shraddha Jain ma'am and IGC today, and what I will be going through is a recent update on infertility, in which I'm focusing my attention on just 2025. So for attended ESHRE, this is a complete summary of what has come out in 2025. So okay. So these are the press releases that were given by ESHRE. That is, microplastics have been discovered in human reproductive fluid. That is in the semen as well as in the follicular fluid. So see where microplastics have reached. The second press release was about PCOS, where they have said that dysregulated epigenetic memory in the embryos offers new clue to the inheritance of PCOS. That means when the embryo is in the mother's womb, some changes take place due to which the woman will develop PCOS after she is born. IUI and IVF pregnancy rates throughout Europe are stable despite an increased uptake of single embryo transfer. Against the odds, a very interesting study where endometriosis has been shown to have 4 times higher pregnancy rates than other causes of infertility like tubal factor or ovulation or male factor infertility. And the best part is that these ovarian stimulation guidelines have come out from ESHRE 2025, which for all of us, whether you are doing IVF or not, is imperative to know. So ovarian response prediction, only AFC and AMH, only 2 things are recommended: age, BMI, basal FSH, inhibin B, basal E2, progesterone, LH, not recommended. For pregnancy prediction, again, AFC, AMH, FSH, LH, estradiol, progesterone, nothing is recommended. So what is recommended? Only age of the woman and BMI. See the importance which is given to BMI. that is directly correlated with the single most important determinant of our treatment. Pre-treatment therapy with estrogen, like estrogen before ovulation stimulation is not recommended. Estrogen and progesterone, both pre-treatment, can only be used for scheduling purpose, like you are doing batch practice or you want to avoid a particular time. You use estrogen and progesterone pre-treatment. Birth control pre-treatment 12 to 28 days not recommended. You are reducing your success rate of antagonist cycles. Pill is used, so and especially if you are planning fresh embryo transfer. Now there is a sandwich protocol, that first we use antagonist, then we use stimulation, then again antagonist. So this pre-treatment, some people use pre-treatment only as clinical trial. Again, this delayed start, ovarian stimulation, where you do day 2, you check, you feel that there are big asynchronous antral follicles, you give antagonists and then start. All this is not recommended. Then a reduced gonadotropin dose is recommended. That the previous slide also was showing about modified natural cycle and natural cycle, not recommended for high responders. Dose is recommended to reduce the risk of OHSS. Antagonist protocol is recommended in high responders, but when you are using antagonists, reduce the dose of gonadotropin, delay nor increase gonadotropin is recommended over conventional. For normoresponders, just use 150 to 225. Again, for low responders, so you feel that there are very few follicles, you want to synchronize all of them, but not recommended. In these poor responders, modified natural cycle is not recommended. Low responders are a heterogeneous group, so people who have very low reserve, these are the ones where you can select modified natural cycle. For low responders, use a higher dose. So don't use 150 or 225, use 300, but anything more than 300 is not recommended. If you are using agonist, then this long agonist protocol is recommended over ultra short. So short and ultra short have gone out of favor. Antagonist is recommended over agonist to give higher safety. So the international suggestion is to go for antagonist. You can go for fixed or flexible, both are equally used. You can use progesterone, PPOS, progesterone for suppression instead of antagonist if you're freezing, good success rate. Recombinant FSH, HMG equally recommended. So the latest recommendation of 225 is RFSH is equal to HMG. RFSH and urinary FSH purified, again equally effective. RFSH highly purified are equally recommended. The FSH with RLH, I don't want to name the brand name, but you all know the newest product which has come out is RFSH with RLH. So what this says is that it is same efficacy as RF. FSH is equally good. They are equally good for women with advanced age also. Combined use of FSH with HMG. Sometimes even I am using half FSH, half HMG. Then now there is a company which is trying to launch this long acting where FSH effect lasts for 1 week in India. So if you look at the long acting FSH, it is equally recommended along with the two brand names, Folitropin alpha and beta, equally recommended. Highly purified FSH and HMG, again equally recommended. Use of recombinant RFSH and RLH is agonist protocol. So again, in agonist, both are equally effective. Adding low dose HCG to FSH not recommended. Stimulation scheme started with gonadotropin and then letrozole, not recommended. Addition of letrozole to gonadotropin for high responders, not recommended. Addition of letrozole to gonadotropin for normal responders, not recommended. Addition of letrozole to gonadotropin is not recommended for even poor responders. Addition of CC to gonadotropin, not recommended for high responders, not recommended for normal responders, and not recommended for low responders. It's equally effective. So for low responders, you can use CC or CC with gonadotropins. What about adjustment? We add antagonists and we think, oh, let us increase the dose of gonadotropin. Not recommended. You can keep the same dose. There is lack of value of dose adjustment during ovarian stimulation, so you must have an appropriate starting dose. Adjuvant metformin, not recommend this during ovarian stimulation is not recommended in antagonists with PCOS. Growth hormone during ovulation stimulation not recommended even in normo or low responders or in women with PCOS. Testosterone before stimulation not recommended. DHEA not recommended for low responders, not recommended for normal responders. Some people start using aspirin. They say this is not recommended for general population or low responders. Use of sildenafil before or during stimulation, again not recommended for poor responders. Myoinositol before or during ovarian myoinositol before or during stimulation not recommended for low responders, and myoinositol again not recommended in non-PCOS women who are undergoing IVF. Non-conventional start of ovarian, that is a random stimulation start. It can be used when you are not planning a fresh transfer and there is no possibility of natural conception. We can use even a luteal start of ovarian stimulation when we are not planning a fresh embryo transfer and no possibility of natural conception. Late luteal phase transfer start of gonadotropin, of course, is never going to be recommended if you are planning a fresh embryo transfer. Double stimulation, yes, you can consider it for urgent fertility preservation cycles. Double stimulation can be used for accuvate cycle, that is accumulation of oocytes or embryos when fresh transfer is not planned. Fertility preservation, if the patient is facing gonadotoxic treatment, then ovarian stimulation for fertility preservation should be started irrespective. These patients come to you in urgency and panic on a horse. If you tell them to wait even for 5 days, forget next cycle, you will never see them again. So you can start stimulation. Remember, it will not make any difference in the pregnancy rate. You can start is recommended. And when you are doing ovarian stimulation for fertility preservation in ovarian sensitive tumors, then use letrozole or tamoxifen. For final oocyte maturation in this patient, HCG is preferred. So remember, HCG is preferred, but of course, be careful that your patient doesn't have a risk of OHSS. Elective oocyte preservation can be done irrespective of the menstrual cycle phase. You can use antagonist protocol or you can use progesterone, that is medroxyprogesterone acetate 10 milligram. You can use it instead of giving the antagonist. For final oocyte maturation, remember in oocyte freezing, there is a favorable of HCG over triprorelin or buserelin or any GnRH agonist, but as long as your patient is not risk for OHSs. So thank you everybody for a very patient hearing and for this opportunity. Ma'am, you're on mute. We cannot hear anything. शारदा जैन मैम, अरे फराज अनम्यूट करो, कुछ भी नहीं सुनाई मेरे को लगा।
Faraz, can we have everybody on the board? Faraz? I think, Shivani, I will say that you have opened a Pandora box. That what Ashray has been thinking about it. They have brought a ovarian stimulation protocol, very easy, very clear guidelines, and I think wonderful, Dr. Shivani. Now we have got a few questions from audience, and they are very simple questions. Probably they have heard about it, that they are very senior people are sitting here. So, question directly to Dr. Brigadier Sharma. How many IVF cycles are typically needed to have a baby, sir?
Madam, actually, I would say within 3 IVF cycles, the patient should conceive. Because first cycle, I mean, it's not only therapeutic, it is diagnostic also. So you find some cause why the patient not become pregnant, you improve on it. And you try the second cycle, whether it is a frozen embryo transfer or a new cycle, and maximum one more cycle. If she doesn't conceive in these 3 cycles, and you have excluded all other immunological reasons and all, then one should either stop it or go for donor cycles.
Sir, another question from you they want to hear. Are there IVF is a risky procedure?
No, well, IVF can be a very, very risky procedure in the unsafe hands because, otherwise, yes, the problems can occur anytime. The only thing is we have to detect it early and then we treat the main, the 3 or 4 problems I can, just count. One is the anesthetic complication can occur at the time of ovum pickup, or there can be internal bleeding at the time of ovum pickup, and for that one must keep the patient in the center for at least 4 hours, and before sending her home you must do the ultrasound to see there is no internal hemorrhage going on. The third is the OHSS, because nowadays there are clear cut guidelines, so I think that is out now, so we follow those guidelines. And very rarely, if the ovaries are big, they can go into the torsion. So you have to tell the patient not to do a lot of physical exercise and jumping and all. Otherwise, there are hardly any other complication which would occur. Multiple pregnancy, twins, or ectopic pregnancy are also possible. But if the transfer is proper and the number of embryos less, that also can be reduced.
Sir, another question from you they want to hear. What happens to the unused embryos?
See, if it is the patient's own embryos, so they have the right to get it, preserved for 5 years as per the new laws. And after that, if they really want to keep it more than that, they have to take the permission from the government, from the appropriate authority. So up to 5 years, they can keep their embryos frozen. But only thing is, we should have a proper consent and a receipt of payment for freezing those embryos. Otherwise, the appropriate authority may come one day and check all your embryos, and you don't have the consent of the patients, or there is no evidence that they have paid for the freezing. That can be a problem. I think this is a new thing which we should be very, very careful. When we are freezing, we must have a proper consent of both the partners, and we should also have some receipt. You might have done with concession, it's okay, but you must have some receipt that yes, they paid this much of amount for freezing it. So you'll be safe, so that nobody will say that you have kept these embryos unclaimed to be sold, for the public later on.
Sujata, over to
Yeah,
you for three
yeah.
questions.
Thank you, ma'am. So thank you so much for excellent deliberations. So, Dr. Gauri, there is a question: is IVF is a painful procedure? Many patients they are very apprehensive about the pain.
By and large, IVF is not a very painful procedure. The only pain in it is that they have to take injections every day. So that is the only, otherwise, by and large, there is no pain. Then after the embryo transfer, some of the women they have problem with progesterone injections when we give. But otherwise, doing a pickup or doing a transfer, these are not painful procedures.
Thank you, ma'am. And the other question is how long it takes to complete one IVF cycle. Like they are worried about their leaves and for how long they have to stay in the town. So how long it
Okay.
takes?
See, by and large, what happens is when, especially those who are working and they're to those who find it difficult to come, or sometimes, the people come from abroad. They have a very specific time, only this much time we they have. So what we can do is we call them on the second day, do the test, start the injections. So if we finish, if we can do a transfer also, in about 20 days, we'll finish it. If we are not doing a fresh transfer, 15 or 18 days, we have done the pickup, then she can go back and come for the transfer in the next cycle, wherein we can manage the endometrial preparation part of it on telephone only, what they have to take, and they can come to us.
Thank you,
So
ma'am.
in a
And
cycle, about 20 days, I would say.
thank you, ma'am. And many times they ask, ma'am, what is the success rate of IVF? So how to explain them?
Okay, in a fresh, whenever you're doing on an average, I would say it's about 35 to 40%, depending upon the condition, and carry home baby rate is 30 to 35%. But if we have frozen embryos, let us say there's a PCO patient, we have frozen about 8 embryos, then we are not going to transfer all of it. We are going to transfer two at a time or one at a time. Then when we do it one, two, or three cycle, they get anything from 60 to 65%. In my setup, it is, we have calculated, it is about 63.5%.
Okay, ma'am.
Sir, they
Thank
want
you.
to hear it from you also, the success rate.
Yeah, see, the success rate would depend upon the age of the woman, what is her, antral follicle count, or what is the semen. There's so many parameters. Based upon that, we can say, okay, this is success rate. Now, if the age is more, if the AFC is less, the success rate is going to be low. And if it is a young patient with just a tubal factor or a mild male factor, there the success rate will be high. So it can be anything between 30 to 60%, depending on the individual patient. It will never be 100%. Whatever advancements we have it, we must tell the patient that we'll never have 100%, because as a doctor, we are just making bodies. We can't put a soul into this. The soul
Uh,
has to come from the God only. So this point we must tell all the patients, because otherwise they all, understand whatever percentage we tell, they think it is 100%. It can never be 100%. It is not a technical or technological failure, because in our specialty there is a God's intervention. The soul has to enter into that embryo, then only this embryo will grow.
I think you have given a very spiritual answer to this.
Yes.
That success rate by and large remains between 30 to 60%, depending upon whether it is a fresh cycle or a frozen cycle. Dr. Shivani, the people they were thrilled about your presentation. They want to hear again from you what is the most significant new advances you heard in ASHRAE. They want you to repeat it. आपको क्या ज्यादा impress किया?
मुझे तो ये समझ आया कि हमारे लाइफस्टाइल की वजह से बहुत चेंजेस आ रहे हैं हमारी बॉडी में। माइक्रोप्लास्टिक्स हमारे एग्स में और स्पर्म में भी घुस चुके हैं अभी। और जो बीमारियां हैं जैसे पीसीओएस विच इज़ रैम्पेंट इन इंडिया, उसका ओरिजिन इज बीइंग फाउंड in the embryo, and they are trying new technologies to try and prevent it from the embryo level. So this just sounds like science fiction now, but this work is going on. Then the endometriosis, जो इतना difficult condition है, which we think is almost a hopeless condition. The pregnancy rates are 4 times that of ovulation and tubal factors, and they have described a lot of reasons for that. So some of the reasons are early detection now, because the problem endometriosis faced, but it was never detected only, it was never found out. Now it is early detection. So
Shwani is gone again.
हाँ नहीं, वही एंडोमेट्रियोसिस का ही बोल रही थी मैं कि that is good news for us and our patients.
And
And I
in
think
case
it
if
is
you want to take 2 minutes more, Shivani?
And then the biggest thing was ki oral contraceptive pill we used to use left, right, and center in IVF cycles. So please stop oral contraceptive pills. Even 12 days, 28 days, avoid it, because now there is again and again data coming that it is reducing the success rate of IVF cycle. So even for patients for other indication who are not yet pregnant, maybe reconsider ki avoid oral contraceptive or birth control pill, go more for lifestyle changes for these patients. Then in stimulation protocols, what is happening is that we used to focus a lot on be giving antagonists, gonadotropin. Now it has come that whatever you do, you are using recombinant FSH, recombinant LH. You all know that new drug, the new brand name which has come. Then there is recombinant FSH, then there is pure FSH. This data is showing that you are not improving pregnancy rate by anything. It is just the same. So don't focus too much on brands and brand names. Just focus more on the BMI, like the BMI of the patient. And you can even use like Munjaro and Ozempic now to reduce the BMI of the patients. So this is what I
Good.
found important.
Doctor, last
So it
question to Dr. Gauri. They want to know how long frozen eggs, sperms, and the embryos can be stored.
How long?
How long?
Matlab theoretically or in India, what is
No,
allowed?
no. For a fertility preservation, a person who has gone for therapy, cancer therapy, and she or he has
Okay,
preserved the things. So how long can it be stored?
okay. Latest guideline, the latest law says in fertility preservation, we can preserve up to 10 years. Beyond that, if we want to preserve, we have to take permission from the board.
So, sir, to wind up today's session, I would like to for the viewers your last comment, Shivani your comment, and Dr. Gauri your comment, and finally Sujata will wind up. Sir,
Yeah, IVF has come a big boon to the infertile couples, and if the timely actions and right approach is done, and the patient is also, always positive thinking, the results can be achieved.
great, Dr. Gauri.
Uh, See today's all those discussion that we have done. Dr. Sharma talked about AI and it's this thing. I talked about fertility preservation. Shivani talked about ASHRAE guidelines. I'll just like to tell the people that nothing is hopeless. You must have all read in the newspapers. Latest is artificial womb. They are producing a child in Japan. They are managed it. So let us hope for a bright future, and maybe IVF will progress further, and we will have artificial wombs also setting in. Thank you.
Sujata?
Yeah. So I just want to say thanks to each and everyone, and I want to emphasize that AI is the human is the father of AI. So we should use AI in whenever required to improve IVF success rate. Secondly, fertility preservation is very important, but patient awareness is very important. Many people they have no idea about this. And Dr. Shivani's talk, we can reduce cost of IVF so much by using normal gonadotropins, by reducing use of adjuvants and other things. This will help us in giving more quality and cheaper IVF in our India, which is the need of the hour. And my regards to Dr. Shardajan ma'am, Brigadier sir, and Dr. Gauri Devi, and my dear friend Shivani for coming and giving such a crisp
No, no. We want to have
presentations.
a
I
last
think,
comment from Dr. Shivani also. Dr.
yeah.
Shivani, what is your last sentence for the viewers?
My last sentence is that everybody who is here is an IVF hero. And I want to congratulate all IVF heroes on World IVF Day and those days where we had nothing but adoption available for couples. We hope to put those days in the past and give everybody their dream.
And I think, I salute to every experts who have been participated in ASHRAE. They have made things very simplified. And many things which we have been doing left and right, they very categorically said that it is not, they are not recommended. So I think, with all the teachers on the dais, I thank you very much on the behalf of the viewers that things might made very interesting. And I'm surprised, the questions were asked were very simple, but I think they bother our patients quite a bit. So thank you very much, all of you. And thank you, Med Talks, for giving this particular platform. I think this particular deliberation will go a long way for. Thank you very much.
Thank you very
Thank
much.
you so much. Thank you.
Thank you.
Faraz, you want to say something?